Hello, my name is Dr. Brian Cheong, and I'm the consultant physician of the Department of Medicine, Hospital Teluk, Intan. Welcome to the first lecture in a series of 3 in conjunction with Antimicrobial Awareness Week, Hospital Teluk, Intan. My lecture would be on the principles of antimicrobial usage. An antimicrobial is an agent that kills microorganisms or stops their growth. They can be grouped according to the microorganisms they act primarily against. For example, antibiotics are used against bacteria and antifungals are used against fungal. Ancient Egyptians have been known to use moldy bread to treat infected wounds. In 1909, Paul Ehrlich discovered that a chemical named asphenamine was an effective treatment for syphilis. In 1929, Alexander Fleming discovered penicillin. Penicillin came from a mole. During World War II, it was nicknamed the wonder drug in its effectiveness to cure infected wounds. In 1942, cases of penicillin-resistant Staph aureus was discovered, while in 1959, methicillin was introduced to counter penicillin-resistant Staph aureus. In 1961, MRSA or methicillin-resistant Staph aureus was reported. In this diagram, we can see the upper part shows antibiotic deployment, while the bottom shows antibiotic resistance observed. 2 things which I would like to point out to you is up to 2005, after that, not many antibiotics have been discovered. Not many new classes of antibiotics have been discovered. That's the first thing I would like to show. So since 2005 until now, 2020, the development of antibiotics have, you can say, sort of dried up. The second thing I would like to show from this graph is how fast resistance can develop. You can see from the introduction of a certain antibiotic within years, maybe 3 years, 2 years, or less, you can see antibiotics, the organism developing resistance towards that antibiotics. So this is a cause for concern and why we should have a good principle in guiding our antibiotic usage. Why is it important to choose an antibiotic properly? We need to achieve an optimal benefit in using antibiotics. We need to minimize the adverse effects of that antibiotic, and we need to minimize antimicrobial resistance. Antimicrobial resistance, according to WHO, just recently, July 2020, it states that it is a global concern. New resistant mechanisms are emerging and spreading globally. The ability to treat common infections affected because of this, resulting in prolonged illness, disability, and death. Medical procedures become high risk because of infections, and this leads to an increase in cost of healthcare with prolonged hospital stay and more intensive care required. This diagram shows the effects of antimicrobial resistance worldwide. Actually, antimicrobial resistance occurs naturally over time, usually via genetic changes or mutation. But misuse and overuse of antimicrobials accelerate this process. What are the ways where we misuse and overuse antibiotics? Number 1, using antibiotics when an infection is not present. Number 2, using antibiotics for viral infections. Number 3, using broad-spectrum antibiotics when organism and its sensitivity already identified on cultures. Number 4, prolonging the duration of antibiotics unnecessarily. Number 5, when the source of infection, or we call source control, is not done. Number 6, not completing a course of antibiotics which is prescribed. Number 7, keeping, using, or sharing leftover antibiotics. And lastly, number 8, use of antibiotics in livestock to promote growth and disease prevention. These are examples of misuse and overuse. And when we talk about misuse and overuse of antibiotics and the development of antimicrobial resistance, there are two concepts that we would like to bring to mind. One is collateral damage. There's a movie by Arnold Schwarzenegger, starring Arnold Schwarzenegger, called Collateral Damage. And on the right, you can see atomic bomb. Okay, what are the concepts related to antimicrobial resistance? In collateral damage, what it means is when we use an antibiotic which kills all types of bacteria, the good bacteria, the bacteria which is not causing resistance, not causing the disease, and also the bacteria which causes the disease. These so-called innocent bacteria are the collateral damage, and this leaves the resistant bacteria, which will then proliferate. So collateral damage in terms of antimicrobial resistance is an ecological adverse effect, namely the selection of drug-resistant organisms and the unwanted development or colonization or infection with multi-drug resistant organisms. For example, if we use cephalosporins, we push development of vancomycin-resistant enterococci, extended spectrum beta-lactamase producing Klebsiella pneumonia, beta-lactam-resistant Acinetobacter species, as well as resistant Clostridium difficile. Whereas when we use quinolones, we push towards development of methicillin-resistant Staph aureus and quinolone resistance in gram-negative bacilli, example in Pseudomonas aeruginosa. Neither third-generation cephalosporins nor quinolones therefore appear suitable for sustained use in hospitals as workhorse therapy. Another concept in antimicrobial resistance is Darwin's theory of evolution. It began with Darwin's theory of evolution. Part of it details selection pressure. The top of the diagram shows a colony of bacteria with different levels of resistance. Red being the highest resistance, yellow being the lowest resistance. When antibiotics are applied to this population of bacteria, the susceptible bacteria, the weak bacteria, the non-resistant bacteria will die. This leaves a small colony of bacteria which is resistant. This bacteria which is resistant will then proliferate and produce a larger colony of bacteria. So this is where we call selection pressure occurs. So examples of common multi-drug resistant organisms are Enterococcus faecium, Staphylococcus aureus, Clostridium difficile, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacteriaceae, consisting of E. coli, Klebsiella pneumonia, Proteus species, as well as Enterobacter species. Now we go to the principles of antimicrobial usage. What are they? Number one, obtaining an accurate infectious disease diagnosis. Number two, what is the most common organism causing the infection? Number three, what is the antibiotic spectrum of the chosen empirical agent? Number four, use of combination therapy. Number five, identifying opportunities to switch to narrow spectrum agent. Number six, cost-effective oral agents for the shortest duration necessary. Number seven, understanding drug characteristics that are peculiar to antimicrobial agents. And number eight, what are the antibiotic adverse reactions? So is there an infection which needs to be treated? First, we have to determine this. This can be done from history and examination, blood and or other specimen cultures like urine, sputum, cerebrospinal fluid, and other supportive investigations like chest x-ray and ultrasound, a C-reactive protein, as well as procalcitonin. We must always remember that not all fever is caused by infection. Fever can also be caused by cancer, autoimmune diseases, inflammation, hyperthyroidism, thrombosis, drugs as well. This is a culture plate with colonies of bacteria growing. So it's very important that we make sure that this person is having an infection and it needs to be treated. Number two, what is the most common organism causing that infection? We can get this information from studies, guidelines, as well as your local hospital data. For example, a community-acquired pneumonia is usually caused by these few organisms: Streptococcus pneumonia, Klebsiella pneumonia, Haemophilus influenza, as well as Mycoplasma pneumonia. Cellulitis is caused by Streptococcus pyogenes, Staphylococcus aureus, and a urinary tract infection is usually caused by E. coli, Proteus mirabilis, and Klebsiella pneumonia. You must know what is the common organism which causes the disease, and this can guide your choice of antibiotics. Next will be the spectrum of the chosen agent. Whenever we treat an infection, we usually take a culture, and the culture results are only available after 24 to 72 hours. A delay, inadequate, or inappropriate choice of antibiotics may result in poorer outcomes and increased length of hospital stay. Therefore, we must choose an agent which can cover the possible offending pathogens, like what we talked about in a few slides ago. But also, we must try to limit the spectrum of the empiric antibiotic. So what we want is to not use an atom bomb when you can use a hand grenade or a machine gun. The difference between an empiric and definitive therapy is in empiric treatment, it is a best guess treatment. It is targeted against common organisms for certain diagnosis. It is based on local data which is available, resistant patterns which are available, as well as guidelines. It is usually a broad spectrum agent covering as many possible pathogens as possible. Whereas a definitive treatment is a narrow spectrum agent targeted to one offending organism. It is usually based on culture and sensitivity results. When should we use a combination therapy? Generally, monotherapy is preferred. In situations where we opt to use combination therapy are when we want synergistic activity. Example, using penicillin and gentamicin for viridans, streptococcus, endocarditis, or when we want to empirically treat a critically ill patient, especially when we suspect hospital-acquired infections, where the bacteria is usually multi-drug resistant, and in situations where we think that there is a polymicrobial infections, example, intra-abdominal infections, and to prevent the emergence of resistance, example in tuberculosis and HIV. Next, we must identify opportunities to switch to a narrow spectrum agent. When we get the culture results, we should switch broad spectrum antibiotics to narrow spectrum antibiotics, i.e., that is to target the offending bacteria. A concept that we call de-escalation from a high-end antibiotic, a broad spectrum antibiotic, to a narrower spectrum antibiotic. This is to limit collateral damage and selection pressure, which will lead to the emergence of resistant organisms. Therefore, in this situation, it is likened to using a sniper rifle instead of a machine gun. Next, we would like to talk about the cost effectiveness of oral agents for the shortest duration necessary. In certain patients who are stable or improving clinically, antibiotics can be given orally or switched from intravenous. Example, in pneumonia, skin and soft tissue infections, urinary tract infections, uncomplicated gram-negative bacteremia, intra-abdominal infection without deep-seated collections. However, certain serious conditions, example, infective endocarditis, meningitis, still require IV antibiotics. Why do we switch to oral antibiotics? Switching to oral antibiotics can reduce the length of hospital stay and reduce the risk of hospital-acquired infections. It is also cost-effective. Examples of drugs which have excellent bioavailability, that is, drugs which, if you take orally, the absorption and the effect is nearly the same as intravenous, the drug given intravenously, are fluoroquinolones, bacterium, clindamycin, augmentin, and metronidazole. When we talk about the duration of antibiotics, longer not necessarily means better treatment. Conditions where short duration of antibiotics are effective, which is about 5 to 7 days, include uncomplicated pneumonia, uncomplicated urinary tract infections, as well as uncomplicated skin infections. I'd just like to quote two studies. One study, a recent retrospective multi-center cohort study, found no differences in the 30-day all-cause mortality between 6 to 10 days and 11 to 16 days of therapy in adults with monomicrobial Enterobacteriaceae bacteremia. In another study, the Community Acquired Pneumonia Organization International Cohort Study compared patients who were treated with antibiotic therapy for a duration of 5 days or less versus longer than 5 days. At 30-day follow-up, no deaths occurred in the shorter control group, while 8 patients in the longer therapy group died. And there was no difference in the rate of rehospitalization at 30 days after discharge. So once again, it just shows shows that in certain conditions, if you pick correctly, you can limit the duration of antibiotics to a shorter period, maybe 5 to 7 days. When do we need prolonged antibiotics? When the infection is caused by Staphylococcus aureus, Pseudomonas aeruginosa, when the source control is not achieved. For example, if you have an abscess and it has not been drained, infective endocarditis, infections of the bones and joints, tuberculosis, myeloidosis, as well as meningitis. These conditions usually require prolonged antibiotics. It is also important in choosing antibiotics that we understand the drug characteristics that are peculiar to this agent. We must know a little bit about the pharmacokinetics and the pharmacodynamics of drugs. Pharmacokinetics are what the body does to the drug, and pharmacodynamics is what the drug does to the body. Many of times, we require the assistance of the pharmacist to help us in this aspect. We need to know a little bit about the drug because we want to know whether it is able to reach the organ involved and whether it is more suitable to be given many times a day or one time a day at a higher concentration. Finally, it is also important that we know a little bit about the adverse effects of the antibiotic. There are two types of reactions. Type A reactions are predictable reactions which are related to the pharmacological action of the drug, whereas type B reactions are unpredictable reactions which are usually not related to the pharmacological actions of the drug. We have to choose the antibiotic with the best safety profile. So, to sum up, use antibiotics when there is a bacterial infection, when we want to reduce collateral damage. Not when we want to reduce collateral damage, but use antibiotics to reduce in a way to reduce collateral damage by switching from a broad to a narrow spectrum antibiotic. Use monotherapy instead of polypharmacy, and we must always get the duration and frequency correct. We must choose an effective antibiotic for the disease and the organ involved, and if possible, and in certain situations, switch to oral to reduce the hospital stay. But don't forget, apart from antimicrobial stewardship and trying to reduce drug resistance, your hand hygiene and your infection control are key components in preventing infection from spreading. This is teamwork. That is why the team for healthcare workers in antimicrobial awareness week is Unite to Prevent Drug Resistance. With that, I'd like to thank you.